What we need to do now is to try to close up with some overall recommendations. And this is something that turned out to be quite popular last year. And so what I'd like to do in closing is just to have Vincent come up and take us through the treatment algorithms and with some discussion points. So please welcome Vincent one more time.
Yeah, thanks. Well, we were just amazed at how so many of you can sit and listen to multiple myeloma for 3 hours. Either it's really interesting or you're trapped and you just don't know how to exit. And there's so many different regimens out there, so we thought we'll simplify it. We all recognize that people are from various countries where access is is a big issue, cost is a big issue. So some of it, if it's unrealistic, pardon me, but hopefully everyone will be able to use some version of this as the drugs get approved. So the first question was smoldering multiple myeloma, and this is just basically a summary, and I think most of us agreed that if a patient is potentially a patient with new myeloma or smoldering myeloma, you would look for myeloma-defining events. If they have myeloma-defining events, it's pretty clear we'll treat as myeloma. If they don't have myeloma-defining events, we are considering them as patients with smoldering myeloma. Now, Dr. Paiva just clearly said that there are some smoldering myeloma patients who are high risk. These are patients with IgA, very high monoclonal proteins, abnormal immunophenotype, abnormal cytogenetics like 414, del17, circulating plasma cells, and so on. And then they have a risk of progression of 25% per year, which is median time 2 years. And then all the rest have low risk. All of us agree that the low-risk smoldering myeloma patients should be watched. All of us agreed that the high-risk myeloma patients should be either watched or placed on clinical trials. This is where we left it. And then there was this brilliant question about, do we really feel comfortable that, what about the high-risk smoldering myeloma patients? Will we ever treat some of them on a clinical trial? And we marked that if the patients got evolving features or multiple high-risk factors, I put it as a gray area because it's gray. You're going to find some experts agree on this, some experts disagree. I take it patient by patient. There are some patients who make me very uncomfortable if they have a very high IgA and they've got deletion 17p and they're smoldering. I try to look for myeloma, and if I don't find it, then you watch them, and if the M spike changes, you just initiate therapy. That is a gray area, but I've marked that down as consider treating as myeloma. I'm more comfortable with that, mainly because of the results of the PITEMA trial showing RD as improving overall survival. And then we moved into newly diagnosed myeloma, and then I think most of us agreed if we had access to VRD, that would be the default frontline regimen, except for frail patients who have multiple comorbidities in which you could do Lendex or even ixazomib Lendex. Now, Dr. Moreau forgot that my job was to talk about induction, and he asked me why I didn't cover transplant. Well, that was his job. But since now I'm at the algorithms, I can at least say that if the patient is a transplant candidate, Dr. Moreau, yes, you should do transplant. And that is the blue box. You do induction with VRD, and then you do an autologous transplant, and then the maintenance really depends on whether they have got high risk or standard risk. If they've got high risk features, most of us use a bortezomib-based regimen. That's about 20% of patients. All the rest, we use lenalidomide-based maintenance. The gray box is that not everybody wants to do an early transplant. Some patients really want to carry on with their life and delay the transplant till later. You saw in the IFM trial, the overall survival at 4 years is 84%, whether the patient chose the transplant arm or the non-transplant arm. So I'm very comfortable in selected patients for delaying the transplant, if that's really their preference. At first relapse, it's really more difficult because it's really limited by access. For example, in Europe, where many of these trials were done, not all of these regimens are available. Daratumumab is available only as a single agent. So this may be unrealistic for some people, but our practice is if the patient is not refractory to lenalidomide, daratumumab Lendex has the best hazard ratio, and so that's the preference. But any of the others in the gray box, which were all tested in phase 3 trials, KRD, carfilzomib Lendex, ixazomib Lendex, Elo Lendex, they're all good. This is not a multiple choice where one person is right. It's just more important to make sure that if you try one and the patient fails, you try the next, and so on. This is a disease of multiple relapses and remissions, and use each available option. If the patient's refractory to lenalidomide, we have 2 approved regimens in the US. One is daratumumab, bortezomib dex, and the other is daratumumab, pomalidomide dex. Both of them would be our first choice, again, because of the hazard ratio associated with dara-based regimens. But that doesn't mean you couldn't try one of the others, and any one of those is fine. One thing to highlight is Cyborg-D, cyclophosphamide, bortezomib dex. If we really start using lenalidomide frontline, transplant, and then len maintenance, it's quite possible that many patients have never seen an alkylator, and alkylator still works, and so cyclophosphamide-based regimens should still be considered. That's all I have. Second relapse I showed last year. I didn't show this year because it's just completely gone out of control. It's multiple choices here, CAR Ts, BCMAs, antibodies. Dr. San Miguel was mentioning bendamustine, IV melphalan. You were mentioning melphalan to me, Jesus, just a few minutes ago. So any of this can be considered, but I cannot give an algorithm for this because it's really out of control. You just have to consider each available option, cost, convenience, what the patient's relapse to, and then make the choice. Thank you. Happy to answer questions.
Thank you so much, Vincent. I think that this is an excellent way for us to end. I would invite our panel. You have any final words of wisdom from the panel here? Okay.
I like that Vincent has mentioned the alkylators are important. In fact, we are going to sell melphalan and cyclophosphamide in 5 years' time, and one of the best drugs to rescue late relapses in multiple myeloma.
All right. Well, thanks so much to our panel. We appreciate you sitting here all afternoon. We hope you enjoyed it. Thank you.